Jeff Coughlin is the Senior Director of Federal and State Affairs at HIMSS. In this position, he leads HIMSS' efforts to build stronger relationships with federal agencies and facilitates the building of a nationwide network of advocates for state-based initiatives that impact all aspects of health IT. Before joining HIMSS, Jeff worked with nonprofit health systems, health IT vendors, professional societies, and trade associations to analyze where they could most effectively influence legislative and regulatory processes and really focus their advocacy efforts. He also spent some time in healthcare nonprofit advocacy world, where he led efforts in policy development, directed outreach to Congress and executive branch agencies, built advocacy coalitions with like-minded organizations, and created a robust grassroots network. Today, we've invited Jeff to speak on all the interoperability efforts and initiatives that are happening right now. So Jeff, I will pass it over to you.
Thank you, and thanks very much for having me here today. So I'm going to just run through. I think John did a superb job summarizing what was in the Trusted Exchange Framework and Common Agreement. As he alluded to, there are several other efforts underway right now related to interoperability. Several comments are due today, so if you see folks kind of scrambling around, that's probably the reason why. But I'm going to just touch on some of the things that that we have underway at HIMSS. So, but I did just want to set the stage and talk a little bit about, again, what's the landscape, talk a little bit about what's in the ONC and CMS interoperability rules, and talk a little bit about what HIMSS's perspective is on those rules. And then we'll probably skip over the questions, but hold those for the panel discussion. So when I think about what's happening in healthcare, this slide really speaks to me on a couple different levels. I think, first of all, it speaks about patient engagement and how patients are becoming more involved and engaged in managing their own healthcare. And I think it also speaks to the IT component and all the information that's available out there, how the information is transferred between entities that may have existed outside of a typical kind of healthcare delivery system, and how it's being transferred between patients and providers, and how those all really interact with one another. So I think one of the big issues when we think about healthcare change is really about value-based care delivery. And I think that that's a term that we throw around a lot in Washington, D.C. And I think what we're really trying to do is shoot for more value-based care delivery and moving out from that typical volume-based care system where billing and care was being delivered on kind of an episodic basis. And now we're looking at kind of delivery to the whole patient, looking at opportunities that could be presented as a result of that. But you can see the different issues that really exist and how they all feed into the foundation of value-based care delivery. Some people call it healthcare transformation. Some contexts we talk about healthcare transformation, but I think it really comes down to healthcare value-based care delivery. So you can see right in the center there is interoperability. So keep that in mind when again, I guess for the this broader conference, of course. But the different components that we have right now, of course, are the ONC and CMS regs, and also the TEFCA draft that's out there. And then thinking about all the different stakeholder organizations and groups that are out there that are applying pressure and trying to influence what those different regulations say, but also talk about what all the different regulations that are out there and how they can impact their business models. So I think all of that is pushing in the direction of a kind of a nationwide interoperability, a broader nationwide interoperability initiative. So what's really happening right now in terms of nationwide interoperability? What we have on the slide here are several different efforts that are underway. So you can see the different organizations that exist categorized by the kind of exchange that they really are encouraging. I'm not going to go too in-depth in this slide, but you can just see that a lot of these efforts are nationwide entities that exist to facilitate the exchange of data. And I would also say there's different maturity levels in terms of the exchange that's happening across all these different entities and organizations. The other important point I just really want to try to emphasize as well is that there is kind of a geographic reach question, but there's also a siloed effort that really exists between much of these, all of these different entities. So a lot of exchange is happening across the nation, but a lot of it is happening in kind of siloed networks. And I think that speaks also and is echoed by the information that ONC produced in a report in 2015. John alluded to some of the work and some of the research that's published out there related to what's happening in the current interoperability landscape. And that has to do with the prevailing market conditions that create incentives for some individuals and entities to exercise the control over EHI. EHI is electronic health information, of course, in a way that limits its availability and use. So just kind of keep that in mind as you're thinking about this. This report was produced in 2015. ONC has continued to receive complaints since 2015 on kind of information blocking. I think those complaints contributed to the development of the 21st Century Cures Act within Congress, and has also contributed to the work that ONC and CMS have tried to engage in related to their current interoperability rules. But I think it's all setting the stage for and building on the experiences that a lot of healthcare stakeholders have occurred over the past several years. So I do think that there are a lot of opportunities to innovate right now. I think that the market is certainly pushing us in the direction of innovating. When I talk about value-based care delivery, talk about new models of care, how to implement those. And then obviously the government is trying to push us in a certain direction related to greater sharing of information, related to more patient empowerment, and so on. So just please keep that in mind as we talk about all the efforts underway today. So to dig a little bit deeper into the ONC and CMS rules, I won't go too in-depth, but again, two different rules. The ONC rule is really focused on 7 exceptions related to interoperability, and those are related to the information blocking that's occurring across the market, and they try to define what the exceptions are to information blocking. The Trusted Exchange Framework, I think John really already covered. The CMS rule really focuses on that patient engagement piece and tries to really focus on how patients can take better control of their data. And this idea, I think, was really introduced by Seema Verma at the HIMSS conference in 2018 in Las Vegas. And what she spoke about was the My Healthy Data initiative. And what My Healthy Data really tries to do is provide patients with electronic access and control over their information so they can share it with whomever they like, whether that is a particular provider or a particular API app. Also, they can choose the provider that best meets their needs since they have control over their own data. And they can help make more informed decisions, which would place patients really at the center of the healthcare system. And folks may have heard about Blue Button 2.0. This is really a subcomponent of the broader My Healthy Data initiative. So a couple of issues that are in the CMS rule. The first focuses on proposing to require payers to make patient health data available through open APIs. And that would support the electronic exchange of data for for transitions of care as patients move between different payers. This would involve payers of all stripes and sizes. So Medicare Advantage organizations, Medicaid managed care plans, children's health insurance plans, and also the qualified health plans that are participating in the federally facilitated exchanges. So another piece that was, I'll have to say, somewhat controversial related to the CMS rule was the use of the Medicare and Medicaid conditions of participation to require the use of ADT feeds to follow a patient that was admitted, discharged, or transferred in a particular facility. So that is a component that CMS required, the use of the Medicare and Medicaid conditions of participation. The third piece right here that I'll just mention is around public reporting of those folks that do not actually notify those providers that answer no in response to particular attestation statements related to whether they are fully participating in interoperability. The next quick piece that I'll just mention very quickly that CMS is proposing relates to the use of payers participating in a trusted exchange network. So they have an actual, they proposed a start date of January 1st, 2020, which probably isn't realistic given when the rule was published. But the idea would be that payers would participate in a broader network to facilitate the exchange of payer data across the entire nation. They do ask the question whether a TEFCA or an ONC Trusted Exchange Framework and Common Agreement could be a model to use. And so that's something that folks have been considering as they develop their comments on this proposed rule. So really quickly, just to summarize what our comments are on the CMS proposed rule is that we definitely are supportive of the efforts to make patient health data available through open APIs. HIMSS also supports some of the transparency proposals that are included in the rule that are related to requiring physicians to make their contact information through the National Plan and Provider Enumeration System, the NPPS, that requires that providers make their contact information available to help facilitate the exchange and help establish trust between different providers. There is also, we all are also supportive of the use of TEFCA for the use of this possible network of networks for payers. But we do question whether the conditions of participation is the right vehicle to use for requiring ADT feeds. We point to maybe possibly using the Promoting Interoperability program as an appropriate vehicle, and we also ask that CMS look to maybe using the Center for Medicare and Medicaid Innovation to try to perform possibly a demonstration program where they could look at different models that could be used. A lot of information that is included in that part of the CMS rule, I have to say, could be a little more detailed in terms of what kind of information will be required to be included in the ADT feeds, and also who that information would have to be shared with as a part of that exchange of information. So what's included in the ONC rule? So what ONC tried to do, in addition to the information blocking provisions that I mentioned, was to try to set a higher level of information and a higher level of certification for the requirements for the health IT developer. So we know about the certification criteria that's included as a part of the ONC rule and the different changes, but they also establish these higher level conditions that they would like to see met. So one of them focuses on information blocking, and that's actually saying that health IT developers attesting to the fact that they're not an information blocker, and also making assurances that they're doing everything that they can to encourage the appropriate exchange of information across the healthcare ecosystem. There's also provisions in here related to communications and making sure that there's not a restriction on communications that are occurring between developers and providers and patients. And APIs and open APIs, and establishing an environment where open APIs can be used to transfer information, and making sure that APIs are published and not allow the information and allow the information to be accessed. Accessed, exchanged, and used is a phrase that's used over and over again to make sure that that is appropriately happening. Also, the idea about real-world testing and allowing that to occur and facilitating that real-world testing, and then attesting to all of these facts. So making sure that developers are actually on the record in terms of exchange of attesting to the fact of these higher level conditions. So I won't go into depth here. This is a slide that I took right from the ONC presentations on this rule, but you can see the different actual certification criteria and the changes that are occurring here, and some of the changes that are removed, updated, revised, and some of the new criteria changes that are going to be required of health IT developers under this new rule. So in terms of APIs, this is really a big issue. When we talk about innovation, we talk about all the different pieces that are out there. So ONC wants the process around APIs and open APIs to be very transparent, and only permitting certain types of fees to apply. Sometimes fees in an API space could act as a potential barrier to exchange. So I think what ONC is trying to do here is level the playing field, and is also trying to make sure that new market entrants are encouraged. When we talk about APIs, we talk about maybe different entities that have not typically worked in a healthcare space that want to be involved in the exchange of information. So making sure that there is a level playing field, so those entities are encouraged to participate. So also, I think the other key point here is around what the description of the fees that have to include all material information. So the person or classes to whom the fee applies, the circumstances in which the fee applies, and the amount of the fee, which is variable, has to include when a fee is different between different kind of market participants, that has to be really spelled out as well, is what is another condition that ONC is requiring. So to jump to the information blocking provision, so there are 4 different regulated actors that are included as a part of the information blocking. Healthcare provider, healthcare developer, pretty self-explanatory. Health information network, health information exchange are included. John alluded to the definition of health information network being the same across what's included in the Trusted Exchange Framework and Common Agreement and what's included in this draft rule. So I think that, again, the idea is that these are the regulated actors that would be required to abide by these different 7 categories that they establish for information blocking. So they do define seven different exceptions. So there are some double negatives here based on what was included in 21st Century Cure. So sometimes it's a little hard to explain. So bear with me. But what ONC was required to define as a part of 21st Century Cures really relates to the reasonable and necessary conditions for activities that do not constitute information blocking. So the idea is that information is going to be should be broadly shared across the entire ecosystem, but there are going to be instances when information is not going to be able to be shared. And so ONC defined 7 different exceptions. So some of them are listed here and around preventing harm. So again, a reasonable belief the practice of not sharing electronic health information will directly and substantially reduce the likelihood of harm to a patient. There's also around the idea of promoting the privacy and promoting the security of electronic health information. Some of the other exceptions that they define have to do with recovering costs that are reasonably incurred. So if the conditions are not in place that two exchange participants, two of those regulated actors, cannot appropriately recover the costs that they would incur, there is certain conditions that have to be met, but that could be claimed as an exchange. And also the idea about responding to requests that are infeasible. Two other ones here related to the licensing of interoperability elements on reasonable and non-discriminatory terms, so as well as maintaining and improving health IT performance. So there are times when health IT systems need to be taken offline or brought down for updates and upgrades. So there are certain conditions around when those come into play and when that would could be claimed as a potential exception to this broad sharing of information. So really quickly, what HIMSS is thinking about related to our response to the ONC rule. So one of the things that ONC does ask in the rule is related to FHIR and to what release of FHIR should be used. And they ask the question whether it should be FHIR Release 2, FHIR Release 2 and 4, et cetera. So where HIMSS came down on this was that we think that the use of FHIR Release 4, FHIR R4, is the direction that we should be going. That's the first normative version of FHIR. So that definitely is we think, a step in the right direction for more broadly sharing information. The other has to do, or some of our other comments have to do with the different fees that are established. So I mentioned that the fees and the fee structure that would be created as a part of the ONC rule, three kinds of fees were set out. So the idea of development, deployment, and upgrade fees, and also value-added services fees. Are two directions that I think HIMSS was very positive on. The third set of fees has to do with usage-based fees, and so we do have some language included in our proposed rule comment letters that talks about that usage-based fees have to have some certain conditions around those. In terms of the information blocking exceptions, ONC, I think, does a great job laying out the different information blocking exceptions and has a lot of information included there. What we are asking for in our comment letter has to do with building on some of those definitions and including more examples so folks can get a better understanding of when the information blocking exceptions could apply, when they could and when the regulated actors could really avail themselves of the information blocking exceptions. So we also do ask, again, I alluded to the fact that Congress required kind of defining the situations when information blocking when these exceptions could apply. But we also ask if ONC could try to define some of maybe the best practices that would be out there that could be used to again, further define what the landscape should look like for those regulated actors so they could get a better sense of safe lanes if certain conditions are met, if certain best practices are abided to, what could be used to avoid any sort of civil monetary penalty or other sort of disincentive that would be required for that. So we do also talk about the definitions around the health information exchange, health information network, electronic health information. So very briefly, what I will say in terms of the definition of EHI. What was included in the rule, it was a very broad definition related to electronic health information. So we do ask that the definition of EHI be scaled back a little bit to include, to be more focused on the U.S. Core Data for Interoperability standard that was also included in the proposed rule. With the caveat that in the next several years, we would like additional data classes to be added to that. Right now, the US CDI really focuses on, I would say, on 20 or 21 different data classes. But I think what HIMSS is encouraging ONC to do is really try to look to the future and try to look for genomic information and social determinants of health information, and also maybe wearables data that would not be included, and maybe the market and the environment is not particularly ready to use and try to exchange that type of data, but make sure that we set up an environment that is looking at that in the near future for possible exchange of information. So thank you. I hope that that was a good brief summary and kind of kicks off our panel discussion. So I will turn it back over for a couple more introductions.